Good afternoon, everyone. Welcome to yet another exciting webinar organized by the CAHO Global Rehab Forum. I'm your host for today. My name is Salumon Chandrasekaran. I work as a physiotherapist. I'm a physiotherapist by background, working as operations and quality specialist in the Emirates Health Services, Dubai, where I oversee CARF accreditation in 17 hospitals. I see Dr. Cyril and many other members from the CAHO core committee, from our Global Rehab Forum core committee. On behalf of CAHO and the Global Rehab Forum, it's my pleasure to welcome all of you to this important webinar. For those who are new to CAHO, CAHO stands for Consortium of Accredited Healthcare Organization. CAHO is a not-for-profit organization based in India, dedicated to advancing patient safety, healthcare quality, and accreditation standards across the healthcare ecosystem. It works through strategic national and international collaborations with organizations like ISQA, JCIA, NABH, and others to build capacity, foster innovation, and drive excellence in healthcare delivery. CAHO serves as a professional platform that supports healthcare organizations and professionals by providing training, sharing best practices, mentoring future leaders, and offering a space for exchange of ideas. By joining CAHO, members can gain access to expert advice, abundant resources, networking, and leadership opportunities. CAHO hosts events, webinars, and training programs to empower healthcare providers and promote collaboration to enhance quality of patient care services. The CAHO Global Rehab Quality Forum is a dedicated platform established in 2024 to advance quality and safety in rehabilitation care worldwide. It brings together rehabilitation professionals, administrators, and policymakers to exchange knowledge, share best practices, and drive innovation across various domains of rehab services. For those who are not part of CAHO, we encourage you to consider joining the forum and get benefited. The membership is free for now. Once you are a member, you will have access to a lot of valuable resources, learning and networking opportunities. You will also receive CAHO newsletter titled CAHO Friday Updates, published every Friday. I'm sure you will be astonished to see the various activities conducted by CAHO each week. Today we are diving into a topic that is becoming increasingly vital in modern healthcare: collaborative healthcare, the vital contributions of physical medicine and rehabilitation specialty. And we have a highly accomplished PMR physician to enlighten us on this topic. Ladies and gentlemen, it's my distinct honor to introduce to you our esteemed speaker for today, Dr. Karthikeyan. Dr. Karthikeyan is a professor and head of Department of Physical Medicine and Rehabilitation at SRM Medical College Hospital and Research Center in Kattankulattur, a suburb of Chennai, India. He completed his MBBS from Thanjavur Government Medical College and MD in Physical Medicine and Rehabilitation from Raja Muthaiya Medical College. He also serves as the clinical director and team physician for Special Olympics Team Bharat India. He is an expert member of two important committees in India: the Subcommittee for Road Traffic Injuries under Ministry of Health and Family Welfare, Government of India, and the Committee for Training and Development for First Respondents under the Government of Tamil Nadu. Ladies and gentlemen, I'm proud to let you know that Dr. Karthikeyan led the medical delegation for India's Special Olympics team at World Summer Games in 2023 in Berlin, Germany, and the World Winter Games 2025 at Turin, Italy. He has 8 publications and 3 patents to his credit, yet so humble. Dr. Karthikeyan, thank you so much for being here to share your expertise with us today. Now, before we hand over the floor to Dr. Karthikeyan, a couple of quick housekeeping notes. Please keep your microphones muted throughout the presentation. Please use the chat box to post your questions or concerns if you have any. We will have 10 to 15 minutes dedicated for Q&A immediately following the presentation. So please try not to interrupt the speaker. Please use the chat box throughout your presentation to post questions. I'll compile them and present them to Dr. Karthikeyan. So with that, Dr. Karthikeyan, the stage is yours. Yeah, over to you. Thank you.
All right. Thank you so much Salman, for your nice introduction. So I felt so excited to know about me through your voice. Thank you so much.
Thank you.
Right. So thanks for inviting me. Thanks, Kaho, for inviting me for this very important topic, the role of rehabilitation medicine to the present day's healthcare. So my sincere thanks to Cyril, my good friend. So topic is the collaborative healthcare, the vital contributions of physical medicine and rehabilitation. So I am representing my institute, SRM Medical College Hospital from Tamil Nadu. The term physical medicine and rehabilitation. So the definition would be the physical medicine and rehabilitation is also known as the physiatry or rehabilitation medicine, which aims to enhance and restore functional ability and quality of life. So this is one specialty which focuses on improving the functional status of a person, thereby maximum the patient's or person's independence in activities of daily living and improve their quality of life. So this is the definition of physical medicine and rehabilitation. Then I would like to reiterate the definition of rehabilitation: a set of interventions designed to optimize functioning and reduce disability in individuals with health conditions in interaction with their environment. So this is the definition given by WHO. So before getting into the topic per se, I would like to uh, give a bird's eye view of the key facts, like what is the health gaps in rehabilitation and what are the challenges we face in our day-to-day life in delivering the rehabilitation phase of healthcare. As per the World Health Organization, rehabilitation is an essential part of universal health coverage along with promotion of good health, prevention of disease, treatment, and palliative care. WHO says an estimated 2.4 billion people are currently living with a health condition that benefits from rehabilitation. The need for rehabilitation worldwide is predicted to increase due to changes in the health and characteristics of the population. That means people are living longer with more chronic disease and disability. Currently, the need for rehabilitation is largely unmet. That is what the WHO says. In some low and middle income countries, more than 50% of people do not receive the rehabilitation what they require. So this is the health gap, which is very huge, which is very evidently in front of our eyes. Globally, the WHO estimates more than 1 billion people suffer any form of disability and further expected to increase to 2 billion by 2030. So that is the warning sign. Nearly 240 million children in the world today have some form of disability. Really, this was really distressing. And they say that 1 in 10 of all children worldwide have disabilities. Really, I need to know the validation of this statement. Then immediately I went and searched for the UN site. The website's homepage itself says this very harsh truth: 1 in 10 children worldwide live with disabilities. So, as the rehab professionals, we have this huge responsibility of managing this big health problem during this present day world. And coming to India, so as we see that there is a significant demographic change between this 2023-2050. So as you see the transition from 23 to 2050, we can see the number of geriatric population is slowly increasing. As you can see that between the 55 to 59 till 75 to 79, this geriatric population is increasing. So there is an increase in the lifespan, but the increase in lifespan will have a lot of morbidities with functional limitations, where we have, as the rehab professionals, we have the responsibility of preserving their quality of life. Of course, the life expectancy at birth, now it has increased from till 65.8, a total of 65.8. right? So it is 67.3 in the years of 2021. And unlike the olden days, the cause of death, previously it was the communicable diseases, but slowly there is a transition to non-communicable diseases with the advancements in vaccination and the prophylactic antibiotics. So the cause of death or the morbidity and the mortality, the transition has happened from the communicable disease to non-communicable disease. So this is the data where we get so that the number of disabilities is going to increase, or the functional impairments is going to increase during the coming days. But what is the present status? Already, what is the status of the disability prevalence in our country? So during the last census of 2011, it says that out of 121 crore population in India, 2.21% of the total population are disabled. So, which is a very big count. 2.21 population of 2.21% of 121 crores. And this fact is not actual. This is not the actual one, because the last census happened in 2011 when the number of disabilities was 7. Now it is 26. As per the disability bill, so the number of disabilities has increased. So obviously between this 2011 to 2025, definitely there is an exponential increase in the number of disabilities. So there is an increase in the lifespan, causing a lot of morbidities with functional limitations, and also there is an increase in the established disabilities. So this is the challenge in front of us. And also the prevalence of disabilities is very significant among the most active age groups between 10 to 19 years and 20 to 29 years. So which is worth considering. And also the distribution of disabilities is not uniform throughout the country. As you have seen, the number of disabilities is the highest in Uttar Pradesh. So, and also the prevalence or the distribution of disabilities varies with different countries. So the health gaps is also not uniform throughout the country. It varies with the different states. So this is the problem statement. It is there in front of our eyes. The number of disabilities is more. The probability of new disabilities is also more. So there is increase in lifespan with more probability of impairments. Prevalence of disabilities in India is also increasing. So what are the challenges in front of us? So we need, as rehab physicians, we have the responsibility of prevention of impairments and disabilities. And last but not least, if at all there is a disability, we need to manage the disability for better quality of life. So prevention and management of disabilities to improve the functional abilities and functional potential for giving a person best possible quality of life is the ultimate objective of any rehab professional. So this I want to reiterate as start of my presentation. So now the healthcare transition is happening from adding years to life, that is the longevity of life, to adding life to years, that is the quality of life. So with all this problem in front of our eyes, so what would be an efficient rehabilitation program? So how it has to be with every institution? A perfect rehab program should have a good vision, mission, and values. It is not just the infrastructure, gadgets, and the people alone. It should have a good vision, mission, values, standard operating procedures, including the referral mechanisms, well-organized rehabilitation team, good documentation. Cost effectiveness is very important because rehab is one phase of healthcare where the cost factor really matters. And academics, training and upskilling of rehab professionals, and research. So these are the various parameters or various mandates for an efficient rehabilitation program which every institute should have. What are the collaborative stakeholders? As the title says, so the physical medicine, how with whom it has to collaborate so that the rehabilitation phase of healthcare is delivered seamlessly to our citizens. So as PMR physicians, we closely collaborate with the tertiary care health professionals or specialists like neurosurgeons, neurologists, orthopedic surgeons, pediatricians, intensivists. So a good rapport between these people is very essential. Very important allied health professionals like physiotherapists, occupational therapists, speech and language pathologists, clinical psychologists, nursing staffs. So these are the allied health professionals who really are the backbone of the rehab care. Technical experts for tele-rehabilitation, community-based rehabilitation, assistive technology, and remote monitoring. And most important is the administrators and managers, especially to manage regarding the financial management of the rehabilitation healthcare. So these are the people with whom the PMR physicians, physiatrists closely associate for delivering the rehabilitation. Now coming to the tertiary healthcare professionals, why we should associate with the tertiary healthcare professionals, what is the importance? So when a person comes with an health problem which needs an acute care, once the acute management is over, for example, a person comes with a traumatic brain injury or a stroke, he undergoes thrombolysis or craniectomy surgically. So after the acute management is over, so even during just after the acute management, the rehab physician comes into place. So during that time, the transition between the acute management and the rehab management should happen very smoothly for the best possible care for the patient. So timely referral call over to contribute even during the acute care, which facilitates the transition of care from acute to subacute and chronic care. So this is very important. And also to take part in rehab interventions on acute intensive care, where a physiatrist do a significant job, that is the prevention of pressure injuries, chest care, ventilator support, DVT prophylaxis, spasticity management, contracture prevention. So mostly when we focus on the acute parameters of a patient, we should not leave these important clinical points that like spasticity management, contracture prevention, and also prevention of pressure injuries. These are also very important. And to establish team coordination, which is useful during further rehabilitation management. So the physiatrist should closely work with these tertiary care health professionals for easy referrals. And most important is rehabilitation care during multiple multi-systemic problems. So this is a very valid, very important clinical scenario. For example, a person in a casualty, I get a call over that, sir, a patient with a brain injury comes to ER. They say that the patient will have a tracheostomy, a brain injury, tracheostomy, pressure injury. He will have some bladder issues, neurogenic bladder. So in ER, the neurologist would say that he's having pressure injuries and a problem with the bladder. So I think he cannot be kept in our ward. Then the urologist comes and he defers, citing the pressure injury. So we need one specialty which really takes care of all these problems. Thereby, holistically, the functional potential of the person is restored. So there comes the physical medicine and rehabilitation, where this does not work as per the specialty. It works as per the functional abilities of the person or the patient. So most of these patients who has all the problems where the specialists defer admission, citing the complication of others, these patients will get admitted in PMR, and we take care of them holistically. Coming to the most important contributors of the rehabilitation, the allied health professionals, who are the core vital role during the rehabilitation phase of healthcare. It's a mandate that there should be an effective communication, coordination, camaraderie with mutual respect is very essential, because our allied health professionals are the people with whom we closely associate for the care, for the patient care. So in our department or anywhere it should be, we should firmly believe this African philosophy, Ubuntu. That is, rehab being a teamwork, it should always go with camaraderie and mutual respect. Ubuntu is I'm because we are. It is always we, not I, when it comes to rehab. So this is my wonderful rehab team. We work as a good team, the team for a good work. That is, I would like to quote two examples. That he's one engineering student who sustained a cervical cord injury. When during the exercise sessions, it is my physios. They say that, sir, there is undue increase in spasticity. So what to be done? So mostly it is not, the spasticity is not just a spasticity. It may be an expression of some systemic problem. So immediately my physios will come and say that they will discuss with me. So when we investigate, it comes to an we came to know the two important reasons like fecal impaction and the severe urinary tract infection. So spasticity is not just the spasticity; it may be an expression of a systemic problem like fecal impaction, pressure injuries, or severe urinary tract infection, or even an ingrowing toenail, some noxious stimulus pressing over the cord. So it requires always a medical supervision for all these problems. So we explored what the problem is. We treated it, and he was not able to stand because of spasticity. After treatment of 2 weeks, we could see the happy face of the patient as well as my physios, and standing the feet of the patient is myself. So again, one good example for a nice teamwork. So he is a person who came with an electrocution injury. So he was just working in his house with some in the washing machine. Suddenly he got an electrocution. He went for a cardiac arrest, and later on he developed hypoxic ischemic encephalopathy. So fortunately, he came to our hospital very early. So we were able to intervene. We rescued him, but at last he had some residual deficits because of ischemic brain injury. So just I'll run this video. It's a good teamwork of my rehab team PT, OTs, and nursing staffs. So he came within a moribund state with all tracheostomy. So nursing staff and physio. These are speech and language pathologies. Or occupational therapists. Yes. So I would say that this is a perfect testimony for our teamwork, all our PTs, OTs, speech and language pathologists, along with our medical management. So he is very thankful to us as a whole rehab team. So now comes another question that whether the rehabilitation phase of healthcare should be treated as a tertiary care or a primary care. So why I had this question? So this is one patient who is from a remote village of Tiruvannamalai district who had a spinal cord injury, got treated, got surgically fixed, but he has never went to any hospital for more than 14 years. So after 14 years, he came with a very moribund uh, pressure injury over the greater trochanter. So it was totally the whole joint got distorted. When we took an X-ray, you can see a very bad X-ray that is total avascular necrosis of femoral head with the overriding of greater trochanter. So completely the pelvis is lost. And when we took an ultrasound, we could see that the one side kidney is completely contracted. So he never know that his body is functioning with only one kidney. So after 14 years, we explored all this with in this very moribund condition. That was the pressure injury on the left. Right side is the one with which we came. When we put our finger inside, it went straight into the hip joint. So though we couldn't completely cover, the wound is relatively better. So this is the scenario. This is one another patient whom we saw in during COVID. He had a pressure injury over the perineum, which is not so common. So there are a lot of persons with complications, which who are spread over the community where they are not being taken care of. I would say that the motor part is to certain extent they know what is the spasticity and contracture, and they are managing by themselves with medications with our physio friends. But mostly what goes underdiagnosed is the bladder complications. They have cystitis, contracted bladder, hydroerythronephrosis, and eventually they get contracted kidneys with the complete loss of renal function. So when this is the problem in front of us, most of the rehab facilities are centralized over the tier 1 centers, and still it has not percolated to the community. So my suggestion or the consensus is the rehab care should be as the primary care, where every person or a patient who needs it has to be served. That is my opinion. So in that case, when the problem is very huge, again, one example is why I am saying that the rehab should be as the primary care. As we see a lot of complications in the community, this one study is called Rosemary Collaboratory Study. This study is was initiated, launched by the Special Olympics International from US. So this study was conducted at 10 sites, which you can see all over the world. And India, from my department, we conducted and we contributed for the global report. So we in that report, we emphasized that we came to know that there is a huge demand or need for the allied health professionals, especially the occupational therapists, speech and language pathologists, special educators, to address to the rehab phase of healthcare. So as we all know that the problems is huge, but the resources, the skilled people are very less when compared to the needs. Then how to manage this gap? There is a huge need, but at the same time, there is a less supply or the less provision of the expertise. So to bridge the gap between the demand and the skills and expertise. So this is what now the challenge that is being faced by the rehabilitation during the present days. How to bridge the gap in rehabilitation, right? There should be adequate number of rehabilitation physicians. So because the medical problems in rehabilitation is very huge. So in that case, the rehab physicians play a very prominent role. I would quote one example that when I went to a school camp, the teachers said that the child has some behavioral issues. He always tend to go to the front bench, though we restrict him or make him to sit in the third or fourth bench. He goes and he never listened to us. So I was not convinced with that. So when we checked for the vision and his eyes, we could see the biter spot. So it was a vitamin A deficiency, the nyctalopia, the distant vision is not there. So the child always goes to the front bench. So when the vitamin A supplementation was given, once the child's vision got improved, then obviously he, even if he is made to sit on the third bench, he was sitting. So actually speaking, it is a medical problem, not a behavioral issue. So it needs the medical supervision or the medical coordination in all these problems. And training of primary caregivers. As I told that uh, when the problem is so vast and huge, the need is very high, we need to empower each and every rehab health professional to give their best, including the rehab physicians, not only the rehab physicians, or physiotherapists, occupational therapists, speech therapists. They are very, very important for delivering the rehab phase of healthcare. We should always give them a due importance, due respect, and take their expertise for the benefit of the people. So rehab physicians as well as our allied health professionals. And also, there is training of primary caregivers. That is, who are the primary caregivers, especially the medical practitioners with MBBS qualification. So there are more than 1,000 PHCs in our, for example, in Tamil Nadu. So in that case, if MBBS doctors are empowered, because we can't expect the scarce resources, skilled resources to be everywhere, like physiotherapists, occupational therapists. So we need to improve the resources with that intention. I would say that even the MBBS doctors should be taught, or they should give a brief orientation about the disability and the disability management. So that is the idea of initially the inclusion of the PMR rehabilitation medicine in MBBS curriculum for certain practical reasons. It was withdrawn along with the respiratory medicine and the emergency medicine. So now the consensus is there that when there is a huge need for rehab concepts among the MBBS graduates, hopefully in near future it will be included in the MBBS curriculum. And apart from these, the adequate number of allied health professionals. So there should be a good number of physiotherapists, occupational therapists, speech and language pathologists, special educators who are the backbone of the rehabilitation care, and periodical appraisals, upskilling has to be given for them. So adequate number of allied health professionals. And not the least is the research and entrepreneurship. So we need to have effective rehab intervention assistive devices, because when there is a huge gap in supply and demand and rehab, that can be matched only with technology. So the implementation of technology is very essential for effective delivery of rehab care. And financial management, especially the health insurance for rehabilitation, is very important. So this is one big gap. And standard documentation for better evaluation of large language models in rehabilitation. We speak a lot about the artificial intelligence and machine learning. These artificial intelligence, they function based on the language models. Even the language models has to be region specific. For example, a person with abdominal pain, is the cause is not the same for a person in India and in US. So here the infectious causes are more common, where in Western countries, the inflammatory bowel diseases are more common. So even the language models on which the artificial intelligence thrives, it has to be region specific. When the region specific language models has to be evolved, we need a standardized documentation, which is very important. So all this document data is very important for any artificial intelligence to function, because artificial intelligence is nothing but what the data it's not coming from heaven. So as good practices, as I was telling, we need to connect people with technology. We need to have a better financial management. We need to have innovative entrepreneurship. So as I say this, let me say, highlight what I'm doing or we are doing in our department. So we face a lot of difficulties in connecting our people with rehab needs. So we started a program called SEED, that is SRM Education for Empowering Persons with Disabilities. So this is one webinar sessions or the meeting sessions where we discuss with our persons with the disabilities or our beneficiaries, our discharged patients, where they can connect with us in our department during a specific day and time on a topic. We bring experts on various topics and they can discuss. So this is SEED what we are doing. And from our department, again, upskilling of resources is very important. So we conduct periodic workshops for our allied health professionals. And this is recently we conducted one uh, workshop for nursing care and neuro rehabilitation, especially when our nurses want to know about the tracheostomy care, peg feeding, rice tube feeding, pressure injury care. So always we need to upskill or we need to empower our team. So which is very, very important, which we periodically keep doing it. So let me skip this video. And from our department, we want to always be innovative. So we, as of now, we have got patent for 3 devices. One is a toilet seat for spinal cord injured. One is a device which converts the ankle foot orthosis into a derotation orthosis. The other one is a self exerciser for paraplegic. So from our department, in my name, so we have 3 patents as of now. And also one important point which we need to know is the health expenditure in India and the catastrophic expenditure. The World Health Organization estimates that 65.1% of our current health is out of pocket. 65.1% is out of pocket expenditure when compared to a world average of 32%. It is because we don't have the policy or the practice of insurance, health insurance. So most of our people has to spend from their pocket. So that really burns them when they come to the rehab. So for the acute care, they would have spent for the surgery, for acute care, a huge amount of money. By the time they come for rehab, they would have got drained by all means. So that is one important factor. We need to manage the finance part in rehabilitation. Every year, 3.5% of Indian population becomes impoverished and 5% face catastrophic expenditure. So in that case, what is catastrophic expenditure is the expenditure that accounts for more than 40% of non-food spending or 10% of household expenses. So most of our people don't have health insurance. Even there is an health insurance, that is the rehab is not covered. So we are, as rehab physicians, we are trying our best. We are persuading the hospital, NABH, all the accredited bodies to include the rehab phase of healthcare within insurance. So this is one interesting article that when it analyzes the benefit incidence part of health expenditure, it shows that most of our families get distorted, affected by the out-of-pocket expenditure with the absence of health insurance for rehabilitation. So finance management in health, rehab part of health is very, very important. So current developing areas and expertise in PMR. So all this time we have seen that what are the challenges we have as rehab, what are the collaborative stakeholders, who are the stakeholders with whom the PMR is working for the benefit of our people, and how we have to empower our team to give the best possible care for our patients, and what are all the challenges. So all this we have discussed. So the current developing areas and expertise, which is the need of our, that is happening in PMR, is the physical medicine rehabilitation is, we focus more on regenerative medicine, neuromodulation, brain injuries and disorders, interventional pain management, sports medicine, including disability sports. The disability sport is the sports with locomotor disability is the Paralympics, and intellectual disabilities, the Special Olympics. And incidentally, I happen to be the National Clinical Director for our Special Olympics Bharat. And we need to focus more on assistive technology and remote monitoring, artificial intelligence, and machine learning. So these are the current developing areas and expertise in PMR, which as rehab physicians, we closely work to meet the needs of our people. So this is one picture just before concluding. This is one picture which taken during my visit to World Winter Games 2025 Turin. So it was a very nice experience where the children with intellectual disabilities are being trained for both their cognitive function as well as their physical strength. So when we put the cognitive function and the physical strength in unison, in synchrony, we came to know that the sports performance is really marvelous, and the medal tally was really significant, was very good. Next to the host country Italy, India had a very good medal tally, much to the appreciation of our Prime Minister. The next day when we returned from Italy, so we got a call from the Prime Minister's office that the Special Olympics team is invited to meet our Prime Minister. I was fortunate to accompany the team, and it was a memorable experience. So this one last slide I always put in all my presentation. Any small good effort, with the compounding effect, it gives a effect. It gives a good result. So 1 to the power 365, 1.01 to the power 365. You just see the difference. So let us all stay united. Let us all stay with all camaraderie and mutual respect. Our only focus is our patients. So let us all stay united, give the best possible for our patients. Let our rehab community long live. Thank you so much.
Thank you, Dr. Karthikeyan. That was an incredibly insightful presentation. You touched upon a lot of points actually, and I was making notes here. You started from the demographics with WHO, provided by the WHO, where there is a transition from communicable disease to lifestyle diseases, and how we need to collaborate. The physicians, the nursing team, the rehabilitation team, how we all need to collaborate. You have shown some wonderful videos, a wonderful video from your own organization, and a few photos, so we could see how you are implementing that in your own organization. So a lot of takeaways from your session, Doctor. Now we will open the floor for questions. So we have 10 minutes for Q&A. Please unmute yourself and ask questions, or you can post your questions in the chat box. I'll be happy to take them to Dr. Karthikeyan. Any question? We're getting some good comments, Doctor. Good talk. Congratulations to Dr. Karthikeyan.
Okay.
Yeah, great presentation, great ideas.
So my mentor, my professor, he has made my day. So he has told great presentation. Thank you so much, sir. Thank you so much.
Oh, okay. Nandakumar sir is your mentor.
Yes. He's my professor. He's my guide, mentor, philosopher, whatever the term you can use. So people say that I have a lot of influence. His influence on me, in my teachings, in my approach. That really I'm happy about it.
Thank you. Any question, anybody? Excellent learning. Thank you. Please share presentation if possible. Okay, we will share the presentation with you. Okay, you will get it in 72 hours from our team. Okay, so come up with the questions. So in the meantime, Doctor, maybe I'll ask you a quick question. I'm a CARF surveyor, and we always talk about interdisciplinary care, the person-centered care. Person-centered care is a much talked about topic these days. It talks about how the physicians, the physiotherapists, occupational therapists, speech therapists, wound care team, the psychologist team, the spiritual services, dietitians, and all those who are involved in this rehabilitation service, how they collaborate with each other, how they communicate with each other. When we go for surveys, when we conduct CARF surveys, it is always a pleasure listening to or watching the interdisciplinary team meeting. during the survey, we interview the staff right from the CEOs to the therapists and all the staff members in different levels. And also we look at the documents, and also we witness the interdisciplinary team meeting. So the team meeting it's actually very, very important. So what do you think are the barriers to this interdisciplinary collaboration, particularly in the Indian context? You mentioned a lot of financial and other barriers. What other barriers do you think are there in India, particularly for interdisciplinary collaboration?
So, yes. So, it is not only the financial, it is more about the attitude. That is, first thing is we need to educate our people. So, what is the outcomes? What are the outcomes which are very realistic? So, the first reason for failure of rehab is when there is a discrepancy between the expectations and the reality. So, we have to be the first level of first counseling. The first phase counseling is very important. Immediately in our unit, once the patient gets admitted, we spend more time with the family members, make it very clear that what is the most probable outcome and what is going to be our role, the family's role. Everything is crystal clear. We make it very clear. So that is very, very important. Most important barrier would be the attitude of the family members, because they spend more time with the patients than the doctors. So we need to involve the family members with all clear ideas. That is one thing. And second is what I face is the interpersonal relationship between the team. So each and every person in a rehab team, they will have their own strengths. So we should always appreciate the strengths and encourage and empower each other. So that is more important. So the team interpersonal relationship, mutual camaraderie is very important. So that is mostly in most of the units that happens, but I never allow such things happens in my unit. So for me, everyone is equal. And when it comes to knowledge, their contribution, so I make sure that everyone is important. So these are the important things which we need to among with the family members, and second is with the team. So once all these things are being taken care of, along with the financial things. Financial is obviously not in our hands. So it is we need to revamp the system actually. So again, the insurance and rehabilitation, there are a lot of practical constraints. In that case, the patient has to be whose care. That is why the most of the hospitals nowadays, they focus more on establishing rehabilitation medicine, because the insurance companies says that the patient has to be under a medical personal care as an inpatient, and the neurologists and the neurosurgeons, they say that our job is over, who is going to take care? So the patient has to be within the hospital. Now who is going to take care? So there comes the need for the new trade called the rehab physicians. So now the corporate hospitals are showing more interest in establishing rehabilitation medicine, because people stay long and they have to be taken care of. So that is the finance part. So these are the problems which we face in rehab, and hopefully everything is being addressed in the nice way, especially among our rehab association. All these things being taken care of.
Thank you, Dr. Kapi. You explained it very well. It's multifaceted actually. You have to collaborate with the family.
Yes.
You have to collaborate with the insurance providers, and also you have your team, collaboration among your team. That is most important.
Yes.
Yeah. So thank you very much. We got 3 more questions. How do we improve our follow-up? Epidemiological data, return to work in Indian challenges and data, work, interdisciplinary work, any algorithm or any suggestions from CAHO tips can help, please. Okay.
So, yes. So actually, as long as the patient is in hospital, irrespective of their family situation, they get the uniform care, right? So only when they go to home, there comes the disparity. That it depends again the family system, how they value the person or the patient. And obviously it is not just the money alone. I have seen people who are very rich who are not being who have not taken care of the person properly, developed pressure injuries. At the same time, a person who is in the thatched house, they are being taken care of properly. It is not just the finance alone, it is all about their attitude. So, first thing is uh, the constraints for the patient to come for the follow-up. So, we face the difficulty. So, that is the reason we started the telemedicine consultations. Actually, that is not the complete solution, but some, at least to certain extent, if the person wants to say, sir, my bladder, I mean, the catheter get blocked. I have certain issues with my defecation. So, for a person to come to a hospital, it requires a lot. It is resource consuming. So at least 2% should come. He cannot travel by normal cab. He has to take an ambulance, which is going to cost 3-4 times than the normal cab. So it requires a lot of resources. So in that case, the patient, they are not coming for the proper review. So what we thought is, okay, at least we need to connect with them for by some means, so that they, at least by seeing the face of the doctor on screen, he will have some reassurance and he will come out with his complaints. So that is the reason we started with the SEED program and the telemedicine consultations. It worked very well. So most of the time, certain things like spasticity management, bladder issues, and then this glycemic control for diabetes, all these things to certain extent we managed with the telemedicine consultation. And if at all we can give them a proper guidance where to go. So we have contacts with the local hospitals, like government hospitals. We call them like, this person will come kindly, because I have friends in almost all the government hospitals nearby. We call them. So this person will come, please take care. So it is all a little extra edge of efforts. So that is one thing. So we need to establish, we practically do telemedicine consultation, and we have a network of hospitals nearby where we will ask them to take care. So this is one. And epidemiological data, it is really a very challenging one, to be very frank. Still now, we don't have a complete data of spinal cord injury in our country. We don't have a SAA registry as of now for various reasons, because there are a lot of constraints in collecting the data between the government hospitals and the private hospitals and all those things. Data are there, but it is hospital centric data. It is not a centralized data. Unless it is centralized, made into a common pool, we cannot call it as a complete epidemiological data used for research and planning purpose. So data are there, but in our center, if you want, again, we can make use of this telemedicine consultation, and whatever whoever the patient who comes, we can do a standard documentation. And return to work in Indian challenges, again, vocational rehabilitation. So most of the centers, they concentrate on acute rehabilitation and subacute chronic. Okay. Only when it comes, a patient is able to walk. So the patient is, you ask, sir, nalla nadakkum neenga, you have to walk. Then, sir, nadande enna panna? So the success of rehabilitation lies, important one is, we need to make them realize the purpose of the rest of their life. Unless they know the purpose, they will not cooperate. Sir, what am I going to do? I mean, you are asking me to sit, walk. Next, what am I going to do? We should make them clear that what is the purpose of their life. What are they going to do for rest of their life? So that makes the rehab real success. And the vocational rehabilitation is very important. Return to work is, the centers has to concentrate more on vocational rehabilitation as per the expertise or the skill sets of the person. So there are a lot of constraints, both in terms of hospitals as well as with the families. So that itself is a very big area to discuss.
Thank you, doctor. We have one more question, two more questions actually. Kindly tell us the indicators regarding neuro rehab.
Okay, kindly tell us the indicators regarding the neuro rehab. The indicators, in the sense, they want to know the prognostic indicators with various brain injuries, spine injuries, indicators. The question, I think,
the question is not
what are the
clear,
indicators? Yes. So prognostic indicators in brain injuries and spine injuries, it's very vast. Like, what is the type, what is the age of the person, whether it is ischemic or hemorrhagic stroke, what is the lobe involved, what is the residual effect. So all these things really, every age of the patient, disease, chronicity, everything has an impact over the prognostic outcomes.
Oh, doctor, there is a clarification actually. The subsequent post is about clarification, is clarifying that. So quality indicators. So
quality indicators, again, you mean to say that, again, the quality in terms of the patient's outcome, quality in terms of patient outcome. So mostly in neuro rehab, we have two important objectives. One is prevention and management of complications, and second is improving the potential. So these two are very important. So for preventing the complications, we have indicators like what are we list the number of complications like pressure injuries, urinary tract infections. If the patient is on tracheostomy, what is the incidence of tracheostomy associated infections, peg feeding? So for every problem, we need to have a indicator. So what is how it is being managed. So that is one part, that is prevention of complications. Second is improving the potential. Again, we have certain validated scales like for the cognitive, motor, speech. So all these, we can use these scales, validated scales, as the indicators for the neuro rehabilitation. And also based on the experience of each and every department, we can have key performance indicators as specified by NABH. But mostly the validated scales can be used as performance indicators.
Thank you, Dr. Karthi. Yeah. Regarding the previous question, I would like to add something. One of the challenges in India is that health is a state subject. Unlike the defense and the railways, health is a state subject. So it's actually very difficult, particularly in India, when it comes to data collection and management. WHO call for action 2030, mandates the countries to have in-depth analysis of the rehab infrastructure, particularly in terms of the resources in the primary health, secondary and tertiary healthcare. How many physiotherapists you have, how many PMRs you have, how many OTs and speech therapists. And so we don't have that data, unfortunately. So the WHO has set this target in 2017, and I think in India we have not started. So it is call for, it's available on Google. WHO call for action 2030. So I think there are challenges, particularly in terms of the resources, and data collection. So I think we are exceeding. We started 5 minutes late, so I thought we'll give maybe just 5 minutes extra. I hope we have no more question here. So good session, all good comments. So we have, are we going to have accreditation for rehab centers like dental and other clinics? Are we going to have accreditation for rehab centers? May I answer the question?
Yes, please.
Yeah, I'm a CARF accreditation surveyor, and as of now in India we have only one hospital that is accredited by CARF, and we don't have any standard that is specific to rehab in India. NABH, the National Accreditation Body, has standards, but it's not specific to rehab. Now coming to dental and other clinics, dental, I believe there are standards. Other clinics, I'm not sure. Dr. Karthikeyan, if you can add.
Dental clinics?
Yeah, dental and other clinics.
You mean? Dental, we have NABH. Do we have, I think we have accrediting mechanisms by NABH.
Yeah.
I mean, even for rehab, I don't think rehab, there are stroke centers, they have a separate mechanism in NABH, but not the exclusive rehab centers. So for accreditation. Right. So I think, are we going to have accreditation for rehab centers like dental and other clinics? Yes, accreditation, as of now, I think NABH is the one important body in India which accreditates the clinics. As of now, we don't have the guidelines exclusive for rehab clinics. So that is why that is what the present scenario is. Of course, we can request the NABH to evolve one, not a problem.
Yeah. And there is a comment from Sri Kumaran. primary or
Yes.
secondary care hospitals cannot afford to have PMR due to space and resource constraints, but major middle class population prefers private secondary care due to cost. How these challenges will be addressed?
So really, this is a very difficult challenge.
Yeah.
That is what I told. The match between the reality and the people expectations to
Yeah.
certain extent. So to certain extent, we are managing. For example, in our hospital, we have subsidized the cost to a greater extent, even more on the education, teaching side as well as on the corporate side. But definitely, this is not only for rehab. In any specialty care, the people's expectations, their needs, and their financial bandwidth is not always matching. So that is always there. But all we should have in mind that we should have the cost cutting, cost effective, effective cost analysis for our services. So I would say that if my management asks, do you want a robo of 1.5 crores, Locomat or any brand? So in that case, they are good. I don't have any comments. But I can't afford for my patients because it is not going to it is not going to make a burden on management for regarding the return of investment, and obviously it should not increase the cost of the health care for my patients. So what is needed, we have to be very conservative when we deliver. To certain extent or to a major extent, we can manage this cost management. So that is what I feel.
Thank you.
You just deliver what really they want.
Yeah. Thank you so much. We are running short of time. So it's time to wind up. Ladies and gentlemen, as we wrap up, we, on behalf of CAHO and the CAHO Global Rehab Forum, we extend our sincere thanks and appreciation to Dr. Karthi. I see Dr. Saril here. Dr. Saril is the chair of our Rehab Forum. Dr. Saril, would you like to say something before we wind up?
Thank you so much. Wonderful session. I can see that there's a lot of effort taken to compile such valuable data, actually. And I think you have put it up in a very beautiful sequence. And the delivery was really great. Much more than what we could ask for. Thank you, Dr. Karthikeyan. A wonderful session. And today our mission is to really make everybody aware about the roles and responsibilities of all of us, keeping patient in the center, patient and the family in the center, and the best interest of the patient, how we all as medical professionals come together, join hands, and work together to create the magic called rehabilitation. Thank you so much for everybody who has participated, and wonderful feedback, a lot of good questions. A few of the questions we could not answer, but we will like to get in touch with you. You can always email to us also. We will definitely address all the queries. But sir, salute you. Thank you.
Thank you so much.
Thank you, Dr. Saril. Thank you once again.